Hey everyone, Professor Davis here, and we're going to now look at antimicrobial drugs. Now, majority of this is going to focus in on antibiotics, but we are going to hit on different medications that also treat other microbial diseases that are caused by like fungus and protists as well. So, an overview of antimicrobial drugs, we do see that they are called chemotherapeutic agents. And a lot of times we think about when we hear the word chemotherapy, we think about cancer treatment, which is true. It's using drugs to treat the cancer, and that's the same thing here. And so when we look at this idea of chemotherapeutic agents, we're seeing that it's used to treat infectious diseases. And it does this mostly by inhibiting their growth. So examples of these are going to be things like antibiotics, which are going to kill bacteria or fight bacteria, antivirals, which are going to help us against viral infections. We have antiprotozoals, which are going to be against protozoas, antifungals, and then anti-helminths, which is worms. Okay, so that's going to be some of the categories. So when we're looking at chemotherapeutic agents, we have to be very picky and selective about their toxicity. Because a lot of these drugs are highly toxic, we want them to be toxic enough to kill what we want it to fight, but with the least amount of side effects for ourselves. And so when we look at this, we want to see that it targets only the pathogen and hopefully leaves us as the host undamaged. Okay, this is not always the case, but that's the goal when we're looking for medications like this. Now, when we look here, it's easier to selectively target bacteria than it is protozoa, fungus, and helminths. Why is that? Well, the reason that's easier is that bacteria is a prokaryotic cell, whereas the others are eukaryotic cells like our cells. And so since there's a distinctive difference between prokaryotic and eukaryotic, it's easier to target the prokaryotic cell than it is a eukaryotic cell. Because then we're targeting something that looks more like us. So it makes it a little bit harder. So prokaryotic cells versus eukaryotic cell type, there are some structural differences that we can focus in on. We do see that we can target protein synthesis. So you'll recall back from Unit 1, the ribosomes were different in their subunits. And so because of that difference, we could use a drug to target that. Another thing is cell wall synthesis. Because our cells don't have a cell wall, we can target the cell wall of other organisms like bacteria, okay, because animal cells don't have it. There's also going to be some metabolic differences that come into play that potentially could help us as well with fighting off different infections. So a quick little review here. We do see that we have Ehrlich and Fleming. We talked about these scientists previously in previous chapters, but I do want to hit on them again because they do play a key role with this particular topic. So first of all, you have Ehrlich, who was the first to use chemotherapeutic agents to treat microbial infections. He used this to treat syphilis, and it's that salvarsan we talked about. This is what they thought was the magic bullet to help treat a lot of different infections, but remember it had an arsenic base, which was also very toxic to us. So it didn't just kill off the bacteria, it also hurt the host. Fleming, on the other hand, remember he accidentally discovered penicillium, which is the main precursor to penicillin, which is an antibiotic. We do see that a lot of microorganisms do naturally produce chemicals that inhibit the growth of other microbes, and this is because they need a way to help protect their growth and their nutrients, and so they produce this, and we're able to take those and make antibiotics out of them. Now, not all antimicrobial drugs are technically antibiotics. Some are synthetic, and when we look at synthetic, that means they're man-made. We make them in the lab, and an example of this are the sulfa drugs that are used sometimes to treat infections. All right, so microorganisms that do produce antibiotics are kind of listed here in this chart. This isn't necessarily all of them, but this is some that produce some pretty important ones that we use maybe on a more regular basis. So we do have the bacillus species. They are gram-positive bacillus, and a lot of times they're aerobic bacteria. They can end up helping create or produce an antibiotic that we call bacitracin. Bacitracin is what we use a lot of times in what we call neosporin for infections and cuts. We also see that we have the streptomyces. These are a filamentous kind of fungus-like soil-dwelling bacteria. They kind of look like a fungus because it kind of looks like hyphae when they are growing. They produce more than half of the world's antibiotics. So they're a really, really important subgroup here that produce a lot of different antibiotics. You can see them here. We have lots of different types. You've probably heard of erythromycin, neomycin, gentamicin. So those are some that they may produce. Fungus can also help produce some antibiotics. This is where penicillium comes into play. Penicillin comes from a fungus. And so these are also going to be useful in helping inhibit the growth of a lot of different bacteria. And so these are just some of the groups that are talked about. Now, when we look at this idea of chemotherapeutic drugs, they do get divided into two kind of types of coverage. When we talk about this coverage, we see that they can either be narrow spectrum antibiotics or narrow spectrum medications, or they can be broad spectrum. Okay, broad means a lot bigger. So if you look at this particular chart, you can see that penicillin has a more narrow group that it can act on. And so if you look here, it's going to be very effective against gram-positive bacteria. But it's not going to be effective against gram-negative or even the chlamydias. We see that it's not going to be helpful in a lot of other areas. But if you look at tetracycline, it has a very broad group that it's going to help with. It can hit the chlamydias, the gram-positive, and the gram-negative. And so a lot of times, if we don't know what's actually causing the infection, a doctor may put you on a broad spectrum antibiotic to start with. Once we culture out what is growing in that wound or in that infection, we then may change the course of medication to a more narrow one, because then we know exactly what we're fighting. Okay, so this just kind of shows you an example that a lot of these are pretty narrow, but there are some that are considered broad spectrum. So now we need to kind of look at how antibiotics or antimicrobials work. Okay, what are their actions? Now, there's two terms we need to look at and we need to distinguish here. So the first is bactericidal. Bactericidal means it kills the bacteria. The other side is considered bacteriostatic. This is going to inhibit the bacteria. Okay, so when we look at these two terms, which would be the best to treat infection? Well, you may automatically think, say, well, let's kill it. Let's use the bactericidal. But in reality, the bacteriostatic is better, because bacteriostatic antibiotics allow for your immune system to also provide defense. This is important because if your immune system can create memory cells, the next time that you're exposed to that particular invader, they can fight it. So this is a really helpful thing. So we want to support the immune system in its fight. We don't want to take over the fight. Okay, so that's the point of the medication. Now, when we look at this though too, sometimes we might want to use a bactericidal type of medication due to the urgency. If it's a localized infection, we may use the bacteriostatic. But if it's septicemia, like it's running rampant through the whole body, we might need to give more support. Or if it's messing with the brain, the blood-brain barrier, the meninges, like in meningitis, we might need to change courses. Another thing we have to look at too with a lot of these medications is, are they oral or do I have to give them through an IV? Okay, so oral medications would obviously be like pills or liquids, and the IV would have to go through into your vein. So you've got to look at those as well. Another one, dosage is super important with these. You have to make sure the dosage is comparable to one that will actually help the individual, and you have to be careful too to not overdose and get them into more toxic levels. And so this is one reason with certain medications, we'll see a little bit later, that they'll actually do blood draws and they'll see where the medication is before they'll administer the next dose, because we don't want to send the patient into a bigger issue because the medication starts to become toxic. When we look at antibiotics, we do see that they can also affect your normal microbiota, which is the normal bacteria you have in your body. And this does cause some issues for us. It leads to the possibility of opportunistic infections. C. diff is an example of this. A lot of times people who develop C. diff, they've been on an antibiotic regimen for something else, and this bacteria then takes advantage of that. All right, so this is a kind of complication that can occur when we take certain medications. All right, so now let's take a look at antibiotics that actually affect different areas of the cell. And so we do see that there are different antibiotics that are going to affect different parts of the cell. So if you notice here, we have some that inhibit the cell wall synthesis. That's the group we're going to look at first. Okay, and we have others. We're going to hit on each of these groups as we go through this video. So the first group is going to be the ones who affect the cell wall, and you can see them listed here. These are some examples. When we look at the ones that poke holes in the cell wall, this weakens the bacteria structure, and it allows the immune system to be able to break in and fight off the invader. The main thing that these guys target is the peptidoglycan that is found in the cell wall. Okay, so this is what they're going to mostly go up against. So I have a little chart here that kind of shows you the examples of those who actually target the cell wall. You have your natural penicillins, so your penicillin G and V. You have some synthetic or semi-synthetic penicillins like ampicillin, amoxicillin listed there. We also have the cephalosporins. The cephalosporins are going to fight, again, that cell wall structure. We have some polypeptide antibiotics. These a lot of times are going to be topical, that meaning they go on the skin. That's what bacitracin is. Vancomycin is really good against gram-positive bacteria. It's used a lot of times for Staph aureus type of infections, and especially those that are antibiotic resistant, it tends to work pretty good against them for now. We also see that there are these antimicrobial antibiotics. These guys are going to help fight against like tuberculosis. Their cell walls are different because they don't have a lot of the peptidoglycan. Remember, their cell walls have the malonic acid, and so we need a different type of antibiotic to help fight them. And so these are just some of the examples of some of the ones who are going to help fight against with the cell wall. So let's talk a little bit more detail about the penicillins. So penicillins are really good against gram-positive bacteria. So they have a good gram-positive coverage. We do see that the penicillin contains what we call a B-lactam ring, and you can see it here in the picture, kind of in the purple. Some bacteria, though, they actually produce a B-lactamase, which is an enzyme that breaks down this ring. If the enzyme in the bacteria breaks down this ring, the penicillins are useless. The antibiotics cannot work. This creates a penicillin resistance, okay? They're able to resist it because they can break down the penicillin and make it worthless. An example of this that took off is MRSA. You might have heard about MRSA before. It's been taken off the market because there was a methicillin type of penicillin that was developed, and bacteria was able to break it down and overcome it too quickly. And this is what created a lot of those antibiotic resistant strands that we call MRSA. Other penicillin derivatives are more broader spectrum. Some of them could potentially fight against gram-negative bacteria. They do have some gram-negative coverage, but a lot of them have to add something to it to be able to do this, and a lot of them will use what we call a clavonic acid, and this is going to be what we see with amoxicillin or augmentin. These are the types of penicillin derivatives that may come into play, and they just have other stuff added to them. Now, just so you know, there are 50 chemically related antibiotics that fall under this term or umbrella of penicillins. So it's an actually very large group of antibiotics. The next group that we want to talk about are the cephalosporins. The cephalosporins are similar to the penicillins, but they have a slightly different B-lactam ring. We do see that the first generation of this group is really good against gram-positive, so we've got the gram-positive coverage. But other generations are more broad spectrum, and they can also cross over and cover gram-negative. You'll notice that a lot of these have an oral route, but they also have the parenteral route, which means that they are given through injections. Not given necessarily through an IV, but they're given through a type of injection. Okay, so this is a little bit different for this group. The next group we want to talk about are the antibiotics or the antimicrobials that fight against protein synthesis. And so if you'll recall, we have a 30S subunit and a 50S subunit when we're talking about the ribosomes in a bacterial cell, a prokaryotic cell. And so with these, we've got certain antibiotics that are going to hit one of those subunits. So what do they actually do? They are going to target these ribosomes, and they are going to inhibit the ability for them to make protein. Remember that proteins are how your DNA is going to help communicate with the cell and allow the cell to do its normal day-to-day activities. And so if we stop that, it's going to ultimately affect the well-being of the cell. And so it's going to cause those prokaryotic cells to not have the proteins they need in order to survive. Right? And so this is what they're going to ultimately do. They're going to attack some part of this protein synthesis process that we call translation. So some examples of the antimicrobial drugs that fight with or use protein synthesis as their main point of attack. These are going to be things like the aminoglycosides. The aminoglycosides, though, guys, they're scary sometimes because they can have serious toxic effects. And this is where, with these specifically, you have to do the blood draws to make sure that the patient is staying within the therapeutic range. The peaks and the troughs are really important in those blood labs, because if they go into too high of a peak, it can have very serious side effects. On the other hand, if they fall too far in the troughs, those medications then are not going to work against the invader. Okay. We also see the tetracyclines. The tetracyclines are not for children nor pregnant women. We cannot give kids or pregnant women tetracycline because they affect the intestinal coliforms too much. Okay, and this then creates too many chances of opportunistic infections. All right, and so it's a really, really big thing to make sure that we're not giving these to those patients. We also see the macrolids are on here, and the main one is the erythromycin. Erythromycin is an alternative to penicillin because some people are allergic to penicillin. And so this one is different enough that they are able to potentially take it. It does have really good gram positive coverage, but it doesn't have a lot of gram negative coverage. All right, and so this is just some of the groups that we see for the protein synthesis, where they inhibit protein synthesis. The next group are the ones who are going to damage the plasma membrane. When we look at the ones for the plasma membrane, the main one that we see is the polymyxin B. This is a topical type of antibiotic, so it's going to go on the skin. And we have to be really careful with these group. Bacteria is going to become very resistant to these if they are overused. So we have to be careful about not using it too often or over prescribing it. The next one are the ones who inhibit nucleic acid synthesis. These are the ones who are going to interfere with DNA replication or RNA transcription. So this is going to be with the DNA kind of level. When we look at these, there are two kind of groups. We see the rifamycins. Rifapan is the main example here, and this is going to inhibit the synthesis of mRNA. We use this most of the time to treat tuberculosis or TB. On the other hand, we do see that the next group are the quinolones or the fluoroquinolones. These guys are going to be really helpful for urinary tract infections. When we look at this, some antibiotics can target the urinary tract specifically, and so these are some of that. So they are broad spectrum. They are used to help, like ciprofloxacin. That one is the main one that you see prescribed to somebody who has a UTI. The next group and last group that deals with this idea of fighting a certain part of the prokaryotic cell is the ones that inhibit the competitive metabolic inhibitors. So in other words, they're going to disrupt the metabolic pathways. A lot of these guys are going to have a type of enzyme setup that does the inhibition where it can turn off the pathway or turn it on when it needs it. This is going to interfere with that process. And so when we look here, this is called Septra, and Septra is broad spectrum, and it's a combination that is widely used for certain metabolic pathway breakups. Like it's widely used in order to help disrupt the metabolic pathways. So to kind of talk a little bit about this Septra group, it is going to have what we call a synergetic effect. It's two types of medications that are used. So you have the trimethoprim and the sulfamethoxazole. These two are going to work together, and that's where the synergenic effect comes into play. They work with each other, where two drugs are going to have a greater effect than just the one by itself. All right, and so it's a combination treatment that we see taking place here, and that's what they call it Septra for short. All right, so just a quick little overview. Remember that antibiotics target bacteria differently, okay, depending on if it attacks the cell wall, the plasma membrane, protein synthesis. It depends on the type of antibiotic. Some antibiotics have a broader range of coverage than others. Example that has a real broad range is tetracycline. Remember that erythromycin is used as a substitute for patients who are allergic to penicillin. Okay, so that's one we can use if you're allergic to penicillin. The next, some antibiotics are used together because they have a synergistic effect. They work best when both are present, and this main one that we talked about today was Septra. Aminoglycosides, that type of antibiotic can be toxic in high levels, so we have to be careful and we have to continually watch to make sure the patients stay within the therapeutic levels in that group. There are some topical over-the-counter types of antibiotics that are out there. Topical meaning they go on the skin. These include bacitracin, neomycin, and polymyxin B. Some antibiotics treat UTIs better than others, and so this is why most of the time they'll do a culture of your UTI in order to find out which kind of bacteria you have. That way we get the right kind of antibiotic to the patient. Now, remember that those mycobacteria are the ones who have a different type of cell wall. They have the myclonic acid. And so rifampin, INH, and ethambutol, those three are going to be really important in helping treat things like tuberculosis and other mycobacteria. Okay, because their cell wall is different than our gram-positive and our gram-negative. So how do we know how much of an antibiotic to give? Like, we don't want to give too little because then it doesn't help, and we don't want to give too much because it becomes toxic. How do we know the just right amount that we need to give to the patient? Well, there's a set of guidelines that helps us standardize this, and it helps us determine these requirements. And one of these tests that helps with this is called the Kirby-Bauer sensitivity test. These are where they use the bacteria and they create a lawn on their petri dish, and then they use different levels of the antibiotic in these discs. Okay, so these discs are saturated with certain levels of antibiotics. They're placed on the agar, and then they go through the process of an incubation. What happens here is that zones of inhibition are created. So there's areas around that if it kills the bacteria, you can see that there's a zone. The zone that's the best zone, okay, that we need to look at a little more closely. If bacteria is growing right up against the disc, that microbe is resistant to that level or that antibiotic. If the antibiotic may be effective in vivo, like inside something that's living, we would say that we mark it with an I, okay? And then the S is where the microbe is sensitive to the antibiotic. And you can see that here by the zone of inhibition. So once we know the levels of the ones that are going to be the most effective, we want to take a second step to find the lowest concentration that is going to inhibit the growth the best, okay? So lowest concentration of antibiotic necessary to inhibit microbial growth is what we call the minimal inhibitory concentration, or the MIC. Now this is important because this is what allows us to be able to make sure that the dosage is not too high where it's toxic, but it's still effective. All right, and so a lot of times they may use these little E-tests to help with this, but they also can use these wells where there's different amounts of antibiotic in each well, and they can see where the bacteria grows and where it doesn't grow. We can see that as it goes across, we have decreasing antibiotic concentration, and we want to find the one that inhibits the growth, but it's the lowest concentration. Okay, and so that's the point of these types of tests. Okay, so if you look here at the doxycycline, you see there's growth at all the levels. So there's growth in all the wells, so it's resistant to that. Okay, so doxycycline is not the antibiotic you would use for this particular bacteria. If you look here at streptomycin, there's no growth in any of the wells, so they're very sensitive to this one, and so you could use the lowest dose. Whereas if you look at the others down here at the bottom, you can see there's no growth in the first three, but there's growth in the last two. This shows you that there is a level that you have to get up to in order for it to be effective. And so this is the idea of giving us that lowest concentration. Another way we can also look at this is called the minimal bactericidal concentration, or the MBC. This is where it's going to kill off all the bacteria. We want to find the lowest concentration of the antibiotic necessary to kill 99% of the bacteria. You'll notice a lot of times they don't give you 100% because they don't want you to sue them. And so because of this, you can put it in different dilutions. These solutions then can be subbed out on the agar, and we can see if growth takes place. So when we look here at this particular MBC, it's about 32. The 32 is when there is no growth present. Okay, when we get to 16, 8, and 4, there is growth present. However, the 4 is going to be the MIC. Okay, so the part that's going to help with stopping inhibiting the growth. It's going to be more what we call bacterial static instead of bactericidal. So we want to talk a little bit about mechanisms of resistance by bacteria. How can the bacteria help resist against these different medications? And so this picture, when we look at this, is going to show some different ways that they can protect themselves. So if we take a look at the first one, we see that they can have what we call an efflux pump, meaning that when the antibiotic comes in, they can shoot it and pump it out. Okay, so they're able to send it out. Another one is where they can block the penetration of the actual antibiotic, where the antibiotic cannot even get in and gain access to the microorganism. Another one is inactivation of enzymes. These guys can come in and they can inactivate the enzymes that are going to be helpful in the antibiotic being effective. And then last, they can actually target the modifications. They can target the DNA and the ribosome levels in order to help fight that. This is what creates a lot of that antibiotic resistance that we see. Okay, so these are some of the tools that the bacteria can have in order to help protect itself. But how do they get these tools? How do they get these differences and changes that allow them to kick the antibiotic out or to make the enzymes not functional anymore? Well, a lot of this has to do with the misuse of antibiotics. And if we will use antibiotics correctly, we can help prevent a lot of this from developing. So antibiotic misuse and prevention of resistance are some things that we need to kind of focus on. And this is going to revolve around education, educating individuals about antibiotics. So for one, antibiotics available without prescriptions in some countries is a problem. So the fact that we can go down to Mexico from here to buy antibiotics is a problem because you may not be getting the right antibiotics to fight the invader that you have, the infection that you have. And then that just disrupts your normal microbiome and it causes issues for you. And it creates antibiotic resistant strands. Antibiotic treatment is used when not recommended or required. So we used to see this a lot where somebody would go in with a viral infection and they gave them antibiotics. That doesn't help them, okay? And so we need to be careful of when they are prescribed. Another one is, as a patient, you don't finish the antibiotics that you were prescribed. You start feeling better, so you don't finish them. That creates antibiotic resistance. Also, supplemental antibiotics in animal feed. Okay, when animals have extra antibiotics present, it could ultimately affect us after we consume them. Also, this is more for healthcare professionals. If you're going into healthcare field, aerosols created by healthcare professionals creates unnecessary exposure to themselves, especially when you're using syringes to deliver antibiotics. If you create that aerosol and you breathe some of that in, it ultimately exposes you and it can create antibiotic resistance. And also inappropriate antibiotic used for the type of infection. If you have a fungal infection, we don't want to give you antibiotics. If you have a worm infection, we don't want to give you antibiotics. We got to make sure that we're giving the right types of prescriptions. Now, because of this, we have to make sure that we are monitoring the use of antibiotics. Many hospitals have a committee to review the use of antibiotics, and we call this an antibiogram. It's a picture of the antibiotics being used. So statistics are unique for each hospital. Like in this particular case, this is showing you a type of hospital. It's showing you the dates that they were collecting this data. Data is generated from antibiotic sensitivity testing on specific pathogens. So this isn't for all infections. It's only going to be for specific ones. They do report the number of organisms isolated within a given time. They report the percentage of sensitivity. They report it quarterly, so several times a year, and this aids physicians in selecting appropriate antibiotic therapy for in-house patients, the patients that are in the hospital, okay? So it helps guide them and direct them based on what infections they are seeing. The next thing I want to talk to you about is antibiotic safety. So when we look here, some antibiotics have toxic side effects. They can cause liver damage, kidney damage, hearing loss, and our geriatric patients are at risk the most. And why is this? Because they have lost a lot of that fat layer in their skin. Medications affect them more severely as they get older. All right, and so those side effects can be more compounded the older we get. We also see that for safety reasons, we need to monitor to make sure that the antibiotics are staying within the therapeutic index. We got to look for peaks and troughs, so blood draws may be required. And this is especially true for gentamicin and tobramycin. Those are two that we have to make sure that we check. We also see that antibiotics can affect birth control, specifically the pill, contraceptive birth control. A lot of individuals will find out that they get pregnant. They're like, but I'm on the pill. A lot of times they get pregnant while they were on antibiotics. The antibiotics sometimes will counteract your actual birth control. We also see that we can cause a hypersensitivity reaction where some people become allergic to antibiotics. This is seen with penicillin and sulfa for a lot of patients. So we also want to look at the fact that some antibiotics are not recommended for children and pregnant women. The dosage is too high for the size of a child, and also we see that it may not hurt the woman, but it can hurt the fetus if they are pregnant. So these are just some antibiotic safety things that we need to take a look at. Now, the last little bit of these notes are going to look at the other groups of antimicrobial medications. We're going to look at the antifungals, antivirals, antiprotozoas, and so on. So when we look at antifungals, these are typically going to target sterol in their plasma membrane of the fungus. Some of them could also target the cell wall because fungus does have a cell wall and it is different. And so that's going to be some of the areas that we're going to target. Remember that these guys are harder for us to treat because their cells are a lot more like ours because they are eukaryotic cells. Some examples are going to be the Griseal fulvin, which is produced by Penicillium. This is going to treat superficial fungal infections that we call dermatophytes, and so they're going to help with, of course, more on the skin. We also have tolnaftate. This is tinactin. You may have heard about fast-actin tinactin. That was kind of their tagline for this type of antifungal. This is a brand of an antifungal that could ultimately be used. These are topical though, so they just go on the skin, so they're more of your superficial type of infections. On the other hand, some fungal infections require us to take oral medication. If this is the case, we have two groups here. We have the ketoconazole, which is going to be an oral medication. And we also have the amphotericin B, the amphoterrible fungicide. This treats systemic fungal infections, the ones that are deep-seated in our bodies. All right, so these are just some of the examples of antifungals. The next one are your antivirals. These are actually super difficult to target because remember, viruses are going to be parasites that are intracellular parasites. They get inside of your cells. And so a lot of times we have to destroy the cell in order to destroy the virus. This creates a bigger issue. And so we want to target things like attachment, so the virus can't attach to an actual cell and get in. We also want to target the uncoating of the virus. If we can target those things, then the cell may be able to survive. We also see they may also inhibit DNA and RNA synthesis of viral parts once inside the host. This is what acyclovir does. Acyclovir is an antiviral that helps to decrease the replication ability by inhibiting DNA and RNA synthesis. We also see other antivirals could prevent the spread to unaffected cells. Interferon is one in our body that does this naturally. It's a natural chemical that's given off. It's called a cytokine. And this happens when one cell gets invaded by a virus. It'll send this signal out to tell the other cells to protect themselves. It's kind of almost like a silent alarm in a bank. It's given off, and so the proper authorities are drawn in, and the other cells are then hopefully going to have a better defense against the virus. And so these are just some of those examples. The next one are the antiprotozoans. This particular group, remember, protozoans are kind of animal-like. They are going to be found a lot of times in contaminated water and things like that. But we have the chloroquine is going to be one of the best ones we use for malaria. Malaria is carried by mosquitoes. And when mosquitoes bite, they can inject the malaria, and the malaria is going to affect your blood. And so we do see chloroquine is one that could fight that. Another one is the metronidazole, which is going to help against the Giardia type of infections. These guys are mostly going to be ones who affect your digestive system. And so this medication is going to help with that. And so these are just, again, some examples that we're seeing for the antiprotozoans. The last group are the anti-helminths. The anti-helminths are going to be the ones against worms. One of the ones that we know the most about and we see used most often is ivermectin. Ivermectin actually paralyzes the worms, and this is going to help you be able to get rid of intestinal roundworms primarily. But we do see that we can use ivermectin as well for scabies mites, okay, so like bed bugs and lice. Ivermectin also has some other uses. I know during COVID there was this big thing where they made fun of people who used ivermectin, but now studies have shown that it actually helps against COVID too, and that's a viral infection. But we do see there are different groups here, and they are going to help fight against different worms, whether they're tapeworms or intestinal roundworms. There are different medications that are available. All right, so as you go through and you start reviewing these different medications, as you go through the chapter, if you have any questions, please let me know.